some of the challenges that we are facing in doing telemedicine, I think the cost, probably the future is not going to be of concern. I think, at the beginning, an establishing of telemedicine service is going to be relatively high, but later on, I think is going to be, is like using mobiles. And even what we are looking to, trying to utilizing the mobile phone in regard to having some form of tele-consultation within the family and then within the home care patients. The challenges that we are faced is an institution dependent factor and enthusiasm of the hosting hospital, to run the services. Sometimes, you'll find, a team or a hospital, they were not really interested in doing a telemedicine with you as a center. Some of them, it's probably mandate, someone who's dedicated. Sometimes is mandated that these physician in rural area or other area, he need to have some time for like preparing the case or presenting the case to you. So probably he's trying to, find a way. Okay, I didn't need the telemedicine. To have a success, you need to have somebody who is moderating this one, or somebody who is in charge of the process in the hospital. Our experience is we have one of peripheral hospital which was ranked as #1 in number of daily telemedicine consultation for both adult and pediatrics. And the reason for that, the coordinator was really active. He moved between units. He makes sure that these teleconsultation have been done. And when this person is moved to other area, a number of referral have been declined. So you really need to have someone who is dedicated, a coordinator who is managing this hospital, make sure this is what happened, this is what the cases need to be done. Other issues that in regard to challenges, sometimes the hospital that is not utilizing that. They only utilize telemedicine as a crisis. They don't utilize it as improving length of stay, decreasing mortalities, trying to decrease unnecessary intervention for patients. So they only use it if they have some pressure from the family. Oh, why didn't you ask or seek help or other? But we find it very helpful for patients and for families and for also local administrative institution. We have been even discussing issue and we have done it many times, end-of-life decision through telemedicine. And we sometimes we invite parents to attend, this conversation, and then some of the parents will be very happy, because sometimes what happens, families get a lot of pressures from their families, extended family member, that why didn't you transfer this patient, knowing that there is nothing could be added in other tertiary hospital. So just the support for the family help in what is a child is receiving appropriate therapy. Probably he didn't need to move to another institution, and they will be probably happy with some form of consultation.
Okay, I think
this is the last multi-center study systematic review that I showed. That actually it was systematic review that I showed in 2021 PICU, and as Dr. Tariq said, family satisfaction was improved with the use of telemedicine, besides improving the outcome as well.
I can summarize. Lack of bidirectional interaction is very crucial to make the process successful. And the second, things start as telephone, but then you could see like the things evolving in televirtual. Many of these will be explored in the subsequent talk of the session of this part. I would like to thank the panelists for their contribution and introduce the second team for the second session.
Thank you, Dr. Saleh, for your introduction for these our senior consultant. Now I want to introduce first myself and also my friend Dr. Saleh and Dr. Yasser. I'm Abdullah Al-Ghubeshi, pediatric cardiac intensivist and pediatric general PICU. I'm the chairperson of the scientific committee for pediatric conference. I'm also the chairperson of pediatric Saudi SLS. I'm happy to have you all here. Just I want to say something about my colleague Saleh Al-Shihri, consultant pediatric intensivist at King Saud Medical City, clinical head of pediatric critical care and pediatric board program director at Cluster 1 Riyadh region. He's the chairperson of the CBR committee and deputy head of ARB committee at King Saud Medical City. My friend Dr. Gazzaz, Yasser Gazzaz, consultant pediatric critical care and cardiac critical care with subspecialty fellowship in pediatric extracorporeal life support at King Abdullah Specialized Children's Hospital and King Abdulaziz Cardiac Center, Riyadh. So, Dr. Yasser.
Assalamu alaikum. So it's with a great honor that I am going to be moderating the next session with seniors of critical care and leaders of critical care. I'm going to start by introducing who's closer to the podium. So I'm going to start with Dr. Abdullah Sharif, who's a consultant pediatric critical care from Mecca MOH. He's as well the chairman of the Pan-Arab Critical Care Medicine, and he as well is the chairman of the Pediatric Intensive Care Scientific Committee in Emirates Critical Care meetings from 2013 till recently. And next, Dr. Abdullah Turki, who is the consultant of a pediatric critical care in King Faisal Specialized Hospital and Research Center in Riyadh. He's as well the chairman of the Clinical Decision Support System Committee, the chairman of Clinical Ethics Committee, and the chairman of Information Governance Committee, and co-chairman of Clinical Advisory Group for the Clinical Informatics Committee as well. Later after is Dr. Ayman Al-Ayadi, who's a consultant in pediatric critical care from King Saud University, King Saud University Medical City. He's the associate professor of pediatrics and pediatric critical care, and he's the vice dean for quality and development in the College of Medicine King Saud University. And last but not least, Dr. Novel Jarian, who's a ex-colleague from National Guard. He's the CEO of the Medical Referral Center and Ministry of Health. He's as well an associate professor of emergency medicine and emergency medical services, and is a consultant of emergency medicine. So thank you all for being here with us today. First, I would like to start with Dr. Novel Jarian to give us an overview about the Saudi Medical Appointments and Referral Center in Saudi Arabia. Can we have the presentation, please?
السلام عليكم، صباح الخير جميعا وشكرا على الاستضافة. الظاهر أنا المتطفل الوحيد على البيدياتريك اللي بينكم، لكن أتشرف أن أكون معكم واستفدت كثير من السيشنز اللي الصباح واتس ريلي انلايتنج. أشكر الدكتورة على also reported and supported. We govern referrals بناحية إن إحنا we look at why these patients were referred, what are the time frames, what are the SLAs we have to go by. We oversee capacity in the hospitals. We also oversee الهيئة الطبية العليا اللي هي مسؤولة عن العلاج في الخارج وما إلى ذلك من مهام. We also coordinate all the medical evacuations across the kingdom and abroad for Saudi citizens. We've established a organ donation support unit to support the Saudi Center for Organ Donation. We also follow performance management, treatment eligibility, Supreme Medical Authority, health missions, الملحقيات الصحية في الخارج ومتابعة المواعيد. الحمد لله الآن جميع القطاعات الصحية مشتركة في النظام. الكوردينيشن ما بين القطاعات الجامعية والعسكرية والتخصصية ووزارة الصحة قائم ومستمر والحمد لله يعني يثلج الصدر. طبعا نتطلع للمزيد دائما من تعاون ومن الاينمنت. أثناء الجائحة وحاليا ما زلنا نتابع جميع الحالات العناية الحرجة في جميع مستشفيات المملكة لجميع مرضى كوفيد. كنا مسؤولين عن أذونات السفر وكانت من أسوأ المهام الحقيقة أثناء اللوك داون في السعودية وجميع الناس اللي كانوا بيسافرون برا لأسباب طبية وغير طبية كنا احنا نتابعها. طبعا أيضا عندنا critical care pathways ومتطلع لمزيد منها خاصة في موضوع البيدياتريك ونشرف على إقفال أقسام الطوارئ في المملكة. كان سابقا يمكن اللي يعرفون المستشفيات يرسل فاكس للهلال الأحمر ويتم إقفال قسم الطوارئ بناء على فاكس من الطوارئ. الآن احنا نتابع الكاباسيتيز في المستشفى وبالكوردينيشن مع المستشفى والهلال الأحمر يتم الإقفال بناء على الكاباسيتي والقدرة على التعامل مع الحالات في المستشفى. ستيك هولدرز كثيرين، الريجوليترز والبنفيشيريز وما إلى ذلك. ما بدخل في تفاصيل يعني طويلة ونبغى ندخل في النقاش، لكن الحقيقة كنت بتكلم عن السلايد هذا بركز على عدد حالات اللي تم التعامل معها في مركز الحالات من ناحية الحالات. 1100 حالة يوميا عندنا خلال السنة الماضية. 1900 إخلاء طبي تقريبا يعني 22 يعني 500 منها كانت إنقاذ حياة، 22 أكمو. 152 إخلاء طبي من الخارج. خط إنقاذ الحياة تعامل مع 73,000 اتصال العام الماضي. لما بدينا في 2016 كان عدد الحالات ما تجاوز 6000 اتصال. نتابع تقريبا 133 KPI والحمد لله من بدأنا في جولاي إلى اليوم حالات التبرع بالأعضاء استطعنا على الحصول من مرضى رحمهم الله تقريبا 98 عضو. ويعني أشوف أن من أهم الأدوار اللي قمنا فيها في المركز أنا بالنسبة لي شخصيا أن زدنا تقريبا التبرع بالأعضاء 160% من العام الماضي. عدد حالات البيدياتريك اللي تعاملنا فيها من بداية من 2019 تقريبا. عدد الحالات through 1937 التلي ميديسن وجزء بسيط من التلي ميديسن كان على تقريبا 9300 اتصال. الان ICU كانت 4500 اتصال. البي ICU 3400 اتصال. بيدز أونكولوجي وحالات سرطان الدم الحاد تقريبا 73 اتصال، وهذا شيء جديد بدأناه في السنة الماضية فقط. والبيدياتريك انفكشوس ديزيز بدأناها مع الجائحة تقريبا 52 اتصال. احنا الآن حاليا نستقبل ما بين 15 إلى 30 اتصال يوميا ما بين بيدياتريك ER بيدياتريك ICU. الافريج كونسلتيشن تايم ما بين 10 إلى 15 دقيقة، مقسمة ما بين ليفلز. يعني عندنا الليفل الأول يتعامل معها لايف لاين ايجنت، هذول ممرضين كريتيكال كير مدربين على التعامل مع الاتصالات هذه. افتر كونسلتيشن مع الطبيب في المستشفى المحيل يربط الكونسلتنت في البيدياتريك ER والبيدياتريك ICU او الان ICU مع الطبيب هذا ويتم نقاش الحالة. الفائدة اللي نراها يعني ما راح اتكلم بعد البرزنتيشن السابق، ولكن قدرتنا على التعامل مع الحالة وأيضا توفير القبول في نفس الوقت. فنقل المريض مباشرة بالتنسيق مع المستشفى المستقبل made a big difference. أنا متأكد أن في أماكن كثيرة للتحسين، ومتأكد أن في كثير من الأطباء الموجودين عندهم تحديات مع الموضوع إما بالإرسال أو بالاستقبال. And we're open for discussion today to see how we can improve this service. أثرها بلا شك عظيم جدا، ويعني يمكن لو تسمعون بعض يعني التستمونيز من العوائل ومن الاطباء المحيلين ما تتخيلون حجم سعادتهم بهذه الخدمه. طبعا الترند اوفر مانثs يعني واضح هنا، يزيد في فترات الشتاء واتوقع لها علاقه بالفيروسز وانتشار الفيروسز. حاولت قدر المستطاع اني اختصر ما يمكن تقديمه عن الخدمه وعن المركز، وشكرا دكتور ياسر والزملاء، وام more than happy for any questions. يعطيكم العافيه.
Thank you, Dr. Naufel, for the brief but informative introduction. Just like from the initial functions of the center, we have organ donation, we have referral governance, we have life-saving, and you showed kind of the numbers. There's like around 1,000 referrals per year for pediatrics. You kind of shed some light, but I would like to know who's kind of responsible for, from medical point of view, during those kind of a phone call or the consultation that comes to the center, asking for, I'm not sure all those calls are for referrals for critical care or just for consultation, and like who's responsible and what happens from the time someone initiates till the time patient arrives to one of the critical care units that was designated.
So the pathway is we have critical care nursing, PICU nursing, who oversee these calls. So they receive all these calls. They filter these calls, and after gathering the important data from the referring hospital, they contact the consultant in the specialty needed, depending on what specialty it is. So if it's pediatrics or it's neonatal, they direct the call to the specialized person. Discussion happens. Our main target is not moving patients. Our main target is providing care in the referring hospital. Overwhelming tertiary care centers with patients that will not benefit from this bed will prevent the second patient from receiving this care. Around 40% of the phone calls we receive are not referred. A lot of people have the perception that 1937 has increased the number of patients referred. الحقيقة احنا decreased it by 40%. Previously, these patients were all referred to tertiary care centers. We don't prevent hospitals from going directly to referring a patient through the electronic system, and the receiving hospital has the full right to accept or reject. But usually what we say is, when you have a critical care patient, moving the patient per se will not make the difference. Early intervention, early guidance, and early support to the team referring this patient will make the biggest difference. It's helped a lot. الدكتورة سألت سؤال قبل شوي على medical legal issues in telemedicine. We have had 2 complaints previously about brain dead patients, post-drowning patients. There was a complaint about these patients. These patients previously were referred. It's much easier emotionally for the referring doctor to get this patient out of his unit rather than dealing with this pressured family that is looking for a second opinion and so on, regardless of the outcome. And we went to الهيئة الشرعية with these cases, والحمد لله the referring doctor was not we احتجنا أقواله بس ما احتاج إنه يتدخل أبدا بأي حال من الأحوال في الرد على الشكوى هذه وإنه حضور شخصيا للشكوى. I think telemedicine is the future. We will never be able to cover the kingdom with pediatric intensivists, whatever we try to do. It's a very niche specialty, very limited number of people, والpressure حقها عالي. فأعتقد إنه having these brains all around the kingdom through a phone call or an application or a camera or whatever we call it, telehealth is a broad concept, is the way to go.
Thank you very much. Just talking about those 2 medical legal issues and the pressure on the receiving units, I would like actually to ask the other members here, maybe Dr. Abdullah Turki, on the impact of receiving those patients from this system to us, in terms of the impact on the safety of the patient and the impact on the unit itself. If you can give us some insight as of one of the coachary centers receiving those specific patients, and as well the other panellaries, but I'll start with Dr. Turki.
Thank you very much for giving me the chance to be with you today. Transportation is, as every one of us know, it's a very serious process. we are probably in the beginning, and what we have heard from the Ministry of Health is very good, to start with. But it needs. I'm sure there will be much more improvement, much more in the process itself. Whether we shouldn't go to courts or anything. These things should be already established in policies, procedures, responsibility at what time, to whom. Of course, me as a receiving institution, my responsibility starts when the patient enters my organization. But there's a lot of things that happens before. We try our best, but it may not be visible to know whether the patient is stable to be transported or not. The pressure on the other end is huge, that they want to get the patient out. But I don't want the patient to come, and we have this, luckily not many times, but we have patients who arrived to the emergency room dead. And that's what no one wants to happen. But this happens if there is no good preparation, if the other end doesn't, have, a good preparation of the patient, these things will happen. From receiving end, the patient is stable to be transported. Dr. Tariq have mentioned about, we have a program that we actually, the cases that's referred to us, we almost do rounds on them on daily basis to check how they are doing, especially when they are then not stable. So we communicate with them on a daily basis after our patient round, and we help them to manage them until they are in a stable condition, because they are not coming basically to the ICU. They are coming for other services, either heart or other organ failure. We don't want them to have trouble until they reach to the destination and final therapy. So we make sure that they are stable to be, and we help them to decide on what mode of transportation, who should accompany the patient. All of these things we try to fix it. This has a very big link to the previous discussion of the telehealth or tele-ICU, and this is also a very big spectrum. I visited two places in the U.S., Emory University or Pittsburgh Children. Pittsburgh Children is running an ICU in Kazakhstan, remotely with a similar model like what Dr. Jabir said, monitors 24 hours, and there is a physician on call. And Emory running a very large number of ICUs within the U.S. One of the strange things that they have an intensivist who stay in Australia because of the time difference. So he will be awake in his daytime, in the nighttime in the U.S. So, they will start to think out of the norms and advance. We are on track. Hopefully that will come.
Thank you so much, Dr. Abdullah. Dr. Ayman, you come from a different center, a different system than At-Takhasusi, where I don't think we have the same telemedicine in all other areas. So how does this system impact you in terms of receiving those patients?
Thank you very much, and I think thank you, Dr. Naufal, for enlightening us about the system and the overall comprehensiveness of the center. And I think this is a great opportunity to thank all your team and staff and the center. And I think this is the way to come for the future improvement. And thank you again for the organizing committee for bringing up an important aspect where we can make a big difference just by discussing the issues, challenges, and how to face them and with quality improvement initiatives. Seeing this from the receiving ends, from a different system, and I think what we have in the university is a little bit different. We receive the call, we receive almost the referral, and then we accept them once we have the bed, and then the patient gets transferred. I worked in some other institutions where the system is a bit different, so suddenly the patient will just arrive to the emergency room without previous communications without clear reports, with sometimes outdated results of the investigations. And this makes a big difference when you receive a patient with a pre-transfer arrangement, pre-transfer communication, and assessing the readiness and what's the specialties needed to be prepared in the receiving end. And this makes a big difference, actually, comparing the two situations, working in two different hospitals. The early engagement as much as possible with the sending end, and I think this is very important. Having a facilitator from the center in the middle until things get just complicated, and then finally the receiving ends will get the access to the patient or the communications with the center. It's a bit late sometimes. So, and I think the earlier the better. And the most important thing also is to have the ability to convince the referring center is that possibly there is good chances that this patient might be managed and treated in the center without being transferred. Nevertheless, reassuring them also, once the patient really needs a transfer, is to have a good access to them. The other challenges actually we face in our center is once the patient received the calls or received the interventions and the treatment, we have difficulty in transferring this patient back. Not the rejection, but it takes so much time occupying a bed, either in the ICU or even in the ward, and both will block the situations for the next patients. So, and I think looking at the system, we are doing a great job, but a little bit fragmented. So there's people receiving the calls, other end or other stakeholders arranging or facilitating or mediating the transfer and the referrals, and the third part receiving the patients. And there's a missing part also. There is no way back. So there is no center or there is no significant or separate agency or institutions that take care of receiving the patient back or having follow-up arrangements. So I think we are starting, but still there is some fragmented islands of improvements. Hopefully we can bridge these gaps over the next future, inshallah ta'ala.
Inshallah. Thank you so much. Dr. Abdullah, we heard just about Dr. Sharif, the kind of the life-saving program and kind of receiving a patient on your side, maybe without prior communication. I think 2 years ago or last year, one of our colleagues is not here today, Dr. Hakim Amani, presented data from the life-saving program where I know it's from the same area, life-saving patients versus patients who come, like matched patients who come to the ER with the same kind of illnesses and severity of illness. They found actually that the life-saving patients had higher mortality, and as you mentioned, some of them will die in ER. So kind of with this issue, what do you think is the future directions that this kind of a whole program should take moving forward?
Thank you very much. Hello. It's okay now. I think the problem with the life saving is, as you said, that the mortality is very high, and I think there are a lot of reasons for this to happen. Now we have two problems for the life saving. Now one of them, they are coming in a very late stage and they will die, or they are not life saving actually. So we are receiving a lot of patients who are not life saving, arriving to the hospital. Sometimes, you know, the problems in the PICUs, we have rooms that has been isolated, so the beds are blocked because of an isolation, and it is not known for whomever advising for the transferring the patients for life saving. So the patient arrives where there is no bed in the PICU, or there is one bed, and if you admit these patients, you cannot handle any patients who are going to be arrested or coded or becoming deteriorating in your hospital. So there is a communication problem here between the people who are making the decision for transferring life-saving and between the consultants responsible for the management of the PICU. This is one issue. The other issue, as I said, that I don't know the way of transferring patients from one hospital to another hospital depends on what. The service, the primary service, sometimes is not available. So if you have the consultants in the primary service, but you don't have the lab, you don't have the equipment, you don't have the facility. Number two, you know, you have children's hospital and we have general hospital. So the neurosurgical cases are going to the general hospital where there is no pediatric intensivist. And sometimes there are problems that are transferring those patients, especially in neurosurgical emergencies, to the children's hospital where there is no neurosurgery services. And patients usually they will die. And sometimes they will go to the hospital where there is the primary service, but there is no pediatric intensivist. And the patients and the physicians in that hospital will struggle. So I think we need to know the scope of service in each hospital. What are the services that the hospital can provide? And we should know how we are reporting the cases. So I'm just talking to Dr. Saleh, who is part of the life-saving process, asking him about the process, and it depends on the reporter, hospital. So they can report you false findings, and based on that you will put your advices. Number two, there is a medico-legal responsibilities for those who are making the decision, and this will make them having a lower threshold to transfer those patients. So maybe this is one of the reasons why you are receiving patients who are non-life-saving. So I think we have a problem with the system, so we need to sit and communicate with the stakeholders who can make the improvement in the process. The problem that we are facing in our hospital that we are very disconnected from the system. So the administration are not involving us, or if we involve because of the case problems. Number two, Dr. Al-Ayadi has mentioned about the cases who are transferring back. Now, we are in Mecca, we are receiving, and sometimes we need to refer. Now, we don't refer life-saving. Most of the time, we are stabilizing the patients, but we need those areas, especially cardiac cases or neurosurgical cases, to be received, genetic cases for diagnosis. So those patients are making a large burden in our system. Now we have deficiency in the laboratory services, we have a deficiency in the surgical subspecialties, we have deficiencies in the neuro services like an EEG, EMG. We don't have all of these. So it is not working. And I think the people in the Ministry of Health, either they don't know or they have a false message from the administration that we have, but they don't have. So actually what we are facing that all the problems are coming on the pediatric intensive care. So I think one of the issues here, main issue is we have an effective communication system with the stakeholders. So the Ministry of Health, if they would like to run that system, they need to communicate with the pediatric ICU people. And this is, I think, the first thing to do. And then we have a lot of ideas to improve that system. We can improve it, for sure. But we need to have a good communication. Thank you very much.
Thank you all. Thanks for the panels for their presentation today and for covering this kind of a very complex issue. Thank you all. I think Dr. Azzam would like to have a word.
السلام عليكم. دكتور عزام من كوكب المريخ الادلت وورد. اديكم العافيه. Excellent presentation and excellent talk. And especially the pediatric transportation, to be honest, and neonatal transportation also. I think you are, before the adult, you had very good program, especially with the Medi-Evac, and I think the adult learned a lot at the beginning. I remember even when I was in National Guard, how strong is the program to transfer patients from around the country. My question to you guys, when are you going to have a national ECMO pediatric program? And we have the leader that can help us. So is there a plan? And I can help a little bit. Sorry, يعني السؤال كده shocking, but I can help. And already we started some cases with the MOH transferring, but it is still not a structured program. I think the team from Riyadh also had some work that has been happening, but I just want to see this as a national program very soon.
Well, I think when we start a service, we need to make, again, I'm coming just to the same issue of the communication. People are not aware that there is a national program. This is number one. Number two, I think you need to choose first few hospitals, study their facility and transport, and if you can do it at their centers, at their hospitals, or you need to transfer these patients, and how we can transfer those patients. So I think first of all, make the people aware that there is a service and it can be done. That is number one. And I think the best thing is just to go and visit those hospitals. I remember first when I was involved in the PISU development project in the MOH, I visited more than one hospital. So you can really know what is the infrastructure there and what do they need and what do you need to support and to start that national program. So I think this is the first thing to do.
Thank you. I think Dr. Azam added one more layer of complexity in a very complex session already. Dr. Azam, just for I think the matter of time, because we want us to attend the opening session, and we have still 2 talks. My esteemed colleagues are going to be around, and I think we can have further discussions as well with the group here, maybe around lunchtime. Thank you. Next, Dr. Abdullah. Do you want to present the next speaker?
Dr. Azam, that we have to sit together with MOH and with all the hospital today to sit together and with the support of the MOH, with the support of the senior colleague, we can do it. It's not a big deal, but need cooperation and need the coordination between all the hospital, either MOH or non-MOH hospital. But we have to sit, if we can sit at the lunchtime together to have a main plan for this.
So I think next we have Dr. Jihad يعطيك العافية. Dr. Jihad is the head of Pediatric Cardiovascular Intensive Care Unit in King Fahd Medical City. He's a consultant of pediatric critical care and is in the Critical Care Services Administration. So thank you, Dr. Jihad, for accepting to present this kind of a very more complex topic about when parents and professionals don't agree.
Thank you very much. Thanks for the organizing committee for inviting me. I was just joking with my colleagues about when you're invited to talk about such complex topic, you know that you're old. They tell you are senior, so this is just a gentle way of telling you you're getting older. The care planning, I have a short time, so I'm going to sweep through the slides and try to give certain messages. So it depends on how you look at it. I'm trying to think about care planning, in what way I'm going to approach it. Okay, in my outline of my talks, some introduction and definitions, ethics when conflict arise, some cases to discuss, and maybe some conclusion and recommendation. So obviously all of us will try to avoid such conflict, and most of the time you will be able to do it. But there's still going to have this certain percentage when you have to have this argument or have a different opinion. From what aspect you can look at it? It can be for a part of your professional attitude, part of the ethics, quality maybe, accreditation, medical, legal, and maybe more. So as you know, this is part of our development as professional, not only the knowledge and the skill, we have to have the right attitude. We all had this oath, and we're looking for the best care of our patient, and we try to minimize harm as much as possible. So when you define the professionalism, you have to look at this as a set of value of behaviors and relationship that underpin the trust the public has in doctors, the trust the public has in doctors. When you look at it in different definition by the US, they're looking at this as a premise of patient welfare, patient autonomy, and social justice. There's a lot of emphasis in the Western culture on the autonomy of the patient. So the premise of the patient welfare, this focus on the altruism, trust, and the patient interest. Patient autonomy, here you have to look at the appropriate medical decision according to the patient preference or the need, and the social justice when you're looking at this as the societal contract that you have with the whole society. Basically here just a lot of emphasis on the autonomy and that you have to look at the patient, what they prefer, what's their value, what do they want. When you look at it from the healthcare quality perspective, the Institute of Medicine put those 6 domains and they put in the center the patient-centered care, meaning providing the care that is respectful of and responsive to individual patient preferences, needs, and value. So you have to respect that. And of course, all of us have gone through this Sabahi now becoming the standard to put this high quality of care and patient safety on the top. And every institution, if they want to practice in Saudi Arabia, they have to go through this and provide the proper standards. In this standard of Sabahi, they put the plan of care. The caregiver developed the plan with input from the family as on top priority. They have this chapter, number 4, which is called provision of care, and another chapter that emphasizes the family rights, which is chapter 7. If you look at the meaning of it, they're talking about the plan of care have to be developed with a collaborative approach between the healthcare team, patients, and the family. It have to be based on the assessment and to meet all patient needs. So the family have to be involved to a great deal. And there's a special emphasis on the infants and children who are really vulnerable patients, and you have to have policy to protect them, and you have to set the ethical standard how to deal with their needs and requirements. When you look at the patient and family rights chapter, they put a lot of emphasis on the informed consent. You have to respect the choices. You have to allow them to refuse or to disagree with you on certain management plan. If you put it in the context of the ethics, we all look at it, how can we provide the best for our patient, the best interest of the patient under the domain of the beneficence, how to prevent the harm, the non-maleficence. We have to look at the autonomy of the family or the caregiver, which is called the parental authority. And you have to look at the distributive justice. Are you doing this fairly to all? Is it fair to do it for some and not for the others? So this is like a spectrum between the two types of paternalistic approach versus the autonomy. And each one of them can be an extreme. He can be the dominant, the doctor who decides, because you have the knowledge, you are more objective, you can decide better than the family. Or you can say the family has the right to do anything they want because they are the best people to care for the child and they know what's best for the family and for all the situation. So why we get the conflict then? Is it just simply the right way or the wrong way? They are right, we are wrong, or the other way around? Or it depends. There's always debate in the ethics when you look at what's the right thing to do versus not right. So a 7-month-old infant came to me from emergency room with fever, irritability, and a brief generalized tonic-clonic convulsion. The meningeal signs are there. Lab investigation suggestive of infection. Brain CT scan unremarkable. Family will not consent to the LP. Do they have the right to do that? So this is another discussion here between the autonomy for the family or the parental authority. How much of authority can be given to a family to allow for this? There's a potential harm from not doing LP for this patient. All of us probably will say yes from the medical point of view, but this is not a simple like a community problems in our society only, worldwide. It's been reported to be up to 5% in the US and much higher in other countries. So this is a guy from Pakistan, Ahmed, and have studied 220 patients. And they look at the refusal of the LP and the length of stay of the hospital and the higher mortality. Obviously, there is a statistical difference in this. So people who refuse, they get more in trouble. And the fear of limb paralysis can be up to 64%, like what mentioned in their publication. So in Saudi Arabia, literature support the same idea, and probably all of you have encountered that. Maybe the number is decreasing with time, but here you're talking about, the study is done in Taif, talking about 60%. 60% they are worried about the side effects from paralysis. This is why they reject the LP. Of course, there are some categories when they're talking, they don't have a trust in the healthcare system, they're looking for alternatives, they're worried about some pain, but the major fact here that they have a wrong notion that the patient might get paralyzed because of the LP. From where they get this information? From a friend, from a family, from social media. It's all things that are really changing over time. But when you look at what you have delivered to the family in certain centers in the US, and they're giving them the instruction, they talk about really simple procedures. Don't worry about it. It can have minor effects, but usually it's benign. So the fact is, what is the risk of having the LP? The risk is extremely low. So they are basing their decision, their parental authority decision, autonomy based on wrong information. And if they get the right information, probably they can change their mind. In the informed consent, there are certain elements that have to be included. The caregiver has to know the benefits of the proposed procedures, the frequency of the frequently occurring and significant risk of the procedure, the consequences of the refusal of the consent, and the alternatives. And unfortunately, many of us don't spend enough time to convince the family, and we go for the alternative. What's the alternative? IV antibiotic inside the hospital for 14 days, for neonate maybe for 3 weeks. Can you imagine the burden that you have added on the healthcare system based only the family having the wrong notion that this might cause paralysis? So if you want to discuss it from the ethical point of view, is this family really looking for the best interest of the patient? Yes, but they're doing that from their perspective, from what they think is right, while we know for sure from medical fact this is not true. This is potential harm that can happen to this patient? Yes, but what can you do about it? Do you consider this some form of child neglect or abuse? Can you report this and escalate it and take action? Until now, this is not happening. Okay, this is the justice part can be tackled from the economical point of view. We are putting the patient inside the hospital. We are occupying the bed. We're using all these resources for a simple procedure that was rejected by the family. We have a child protection law that was adopted in 2015. Failing to complete the child compulsory vaccination is considered a form of neglect. And this is something forced by the authority. Maybe this is what's missing here. Can we have such thing like that? And it said also in the lower part, any act that may threaten the patient well-being, physical or psychological well-being can be considered a form of neglect or abuse. So something to think about. So the parental refusal of recommended treatment is one of the problems in ethics that's not reported frequently. When you look at the ethics journals, they are talking more about the end-of-life problem, something that attracts the attention of the people. But the refusal of the therapy is not one of them. So can you override this parent's medical decision for their children? They have a review of the literature, systematic review done, and looking at what categories they can have the right, or ethically it is justified for the physician to override their decision. And they have put those 9 ethical framework that's been reported in the literature. And on the top of that is the harm principle. If you believe what's done by the family, it can potentially cause harm to the child, you have to act. The best interest is also in this, and the balance of the cost-benefit is on the low on the list, like it's considered there. I'll give you a challenging scenario that I encountered early also in my practice. 10-month-old infant with bronchitis and impending respiratory failure. The blood gases is borderline. Patient is just huffing and puffing, and decided by the intensivist it's better to intubate. The grandmother come crying, said, don't intubate. Please, do not intubate this patient. Why she asked for that? With tears. She is caring. She is so much conscious about this baby who's having the responsibility for. Because she has the notion that if this patient go on mechanical ventilation, he's going to die. This is not really a strange concept, because in other areas of the country, maybe this is happening. So you cannot say this is unfair or not reasonable or not rational approach. So what to do at that time? Will you intubate or give it more a chance? Keeping in mind that at the night time things might happen and you might get the child. A 2-year-old child who was revived after 15 minutes of CPR, after drowning, the father requests to stop all the support and disconnect from mechanical ventilation 2 hours after admission to PICU. He doesn't want handicapped child, as simple as that. We don't have the facts. We don't know how bad the injury. But this is how much authority he's asking for. Will you grant him this authority, or this is on the other side? You rejected, you refused it based on, okay, still I don't have enough information to decide. Looking for the again, the principles that govern the ethics or the principalism theory of thought, beneficence, best interest of the patient, non-maleficence, no harm, looking at the consent or autonomy to a certain extent. When there's irrational family, maybe you have to change that, and look at the resources and the justice principle. I'll go the extreme now. I'll give you a topic, or I'll give you a scenario from the literature. And so some of the senior doctors here, they will think I'm crazy when I'm presenting this one. Somebody with trisomy 18 and having hypoplastic left heart syndrome. The family want to do everything. They started the therapy. The surgeon said, no, it's futile. They went on social media. So elaborations went to the ethics committee, and finally one hospital accepted to take the patient and give this or do the surgery in another center. The insurance company declined. So what to do in this case? The ethical issues of the moral problems is when we have this conflict between the values, what the family wish for, what we think is right, and do we respect their rights or not? There's a fair, there's a justice, and if we are not sure, morally speaking, what to do. But some of us will say that. You are crazy. Trisomy 18 and hypoplastic left heart. What about person-centered care? We always emphasize, give them what they want, give them what they wish for, respect their opinion, understand their values. So the fact is, I'm going to go fast because I don't have time. Trisomy 18 is not fatal anymore as it used to be in the previous years, because if you provide them treatment, if you give surgeries, if you do the proper therapy, they might survive. You will be surprised that this is case reports of 26-year-old trisomy, the mosaic type. This is by the media saying there's a 40-year-old trisomy 18. Don't know if this is true or not. They have a higher mortality if you go to heart surgery. They use a lot of resources. But now they are considering in the literature that you can do surgery for this kind of cases. The palliative surgery, which consists of the VT shunt versus Glenn, and there's a Fontan. If you look at them alone in healthy children, they have a good survival, more than 90% in good center. So it's not always that simple. Some dramatic cases force doctors to reevaluate long-held ethical norms and ingrained patterns of practice. This ethical norm also shifts gradually and almost unnoticeably over time. This is something they never thought about 20 years back. This is now something they are considering as acceptable. So this case, I just want to add more complexity to what I have discussed before, reveal the intersection of parental values, clinical judgment, ethic consultation, insurance company decision, the financial part, who's going to pay for it, okay, and the embarrassment, and the social media publicity. When you go on social media, when you publicize things, maybe you change your mind, or maybe look at you as a doctor, as a bad doctor. Come on, what are you doing? You are killing the kids. You have to do something about it. So this factor can lead to a complex ethical deliberation and decision. So from the parents' perspective, try to understand their thinking. They are not bad. They just basically think from their point of view. They want to advocate for the child, have unconditional love, sacrifice to some extent. Conclusion, you need the medical facts. Just don't rush to the conclusion when you're talking about ethical dilemma, what to do. Do no harm is probably the top priority when you're discussing the children care. Best interests principle next. Family authority have to be respected unless they are irrational, and futility should be defined clearly. Use the resources discussion last when you're talking about the justice, and every case is unique, and there is a solution usually within those details, the nuance of the case. Thank you very much.
Thank you, Dr. Jad. I'll move next to Dr. Mohammed Hassani, who's a pediatric critical care consultant and King Fahd Medical City. He's as well the Director of Quality Administration and the Chairman of Medical Records Committee. Welcome, Dr. Mohammed.
Assalamu alaikum. Thank you for the organizing committee for inviting me to talk about how we can make care better in the pediatric ICU. So my outline is I will go quickly about the domain, risk management and KSA governance, patient safety culture, human factor and just culture, and I will end with the references. So when we talk about the dimension of quality, as Dr. Jihad has been highlighted, I would like really to emphasize that the first thing that we have to focus is do not do harm. which is the first and very important concept that we have to adopt before we talk about resources and efficiency as an overall. As ISO definition for the risk is the effect of uncertainty. When we are talking about probability of something may happen outside what you are planning to be done, and usually it will be characterized the risk by probability and the impact that may happen. When we look to the risk, there is a risk category. It is not only one risk like clinical and operational. We are talking about financial risk, talking about human capital and staff turnover, legal, technology, and disaster like what we have in COVID-19. So when we look to the concept of risk mitigation, we are not trying to eliminate the risk in our healthcare. Risk or error can happen, but we need to prevent the harm from happening. So here, in a standard ESR, essential safety requirement from our SBAHI accreditation, the hospital has a process to ensure correct identification of the patient. Why? We don't need to do mistakes that harm the patient. Disaster drill that we are doing on a regular basis, and business continuity plan to ensure that whenever a major threat will affect our organization, will take care of, and we have our recovery plan for it. If you need to evaluate the quality of care that you are doing in your ICU, for example, now the telemedicine, the referral, the risk management, we'll look to that from the Donna Biden in 1966 when he described that there are 3 dimensions we have to focus on. What is the structure that you will operate? What is the process to lead to the outcome that you are looking for? Starting by the structure, what we are looking in the structure. First of all, what is the strategic direction for any program you want to do? Who is the governor body? What is the organization structure? Why? Because they have to provide you with the appropriate human resources to establish your program. And here we are talking about risk management. What other resources that they have to provide, like reporting system, staffing, equipment, facilities. Then we look to the processes, and here what you will do, education of the staff, establish a program, education, staffing. Then you look to the outcome that you would like to be achieving in your ICU or on your program. What KPI are you trying to achieve? How important is telemedicine or referral or risk management? What you would like really to achieve? So you need to measure that outcome to ensure that you're able to have a success plan in what you are trying to do. This is our regulatory body at national level. The bigger umbrella is Saudi Health Council. Under that, SBAHI, our accreditation, Ministry of Health, and other army hospitals. One of the important established regulatory is Saudi Patient Safety Center, and as well as Saudi Council for Health Specialty. This is from SBAHI chapter when we talk about quality and patient safety from standard 13 to 28, mainly talking about risk management. This is some of the regulatory document at level of national level from Ministry of Health and Saudi Patient Safety. And this is suggested framework or organization chart in how we can do our risk assessment, starting from down by the risk registry or your risk reporting. Then you have a risk management team, quality and patient safety committee, and ending by governor body when we send all our risk registry to Ministry of Health. This is the risk assessment framework, and here you can say that you need to establish the context, and you have to have the risk identification, very important risk identification, by reporting, engaging the staff. And we are looking future-wise that family, they can report the risk in our system. Risk analysis by probability and impact, then you need to define the cut in where you would like to establish the treatment for that risk according to your resources and the culture that you are operating. This is a picture for the risk registry by Ministry of Health. And the risk matrix here showing that the red zone is the very high risky area that have severe incidences or sentinel event, and the green area where we are talking about the minor. All of them is important, but some of the organization is still operating in the red zone while other advanced patient safety, and they are mainly working in the green area and utilizing every single near miss to prevent an error to happen and lead to harm. So I would like now to go a very important topic, which non-punitive response to the error. We can establish resources, policies, procedure, education, manpower, system, reporting, but if we did not know how to handle our staff when there is an error happen, that really will be a bottleneck to enhance the patient safety culture. And they define it by staff feel that their mistake and event reported are not held against them, and these mistakes are not kept in their personal file. So this is the hospital survey on patient safety culture by Saudi Patient Safety Center, and we have already 4 cycles started by 2018. This is 2018 and 19, and the common observation on this and the area for improvement is still we have a blaming culture, as well as we are short of a staff that will be able to facilitate the risk management, and the communication openness still is an area that we need to focus. When we look to the subsequent survey, this is the statistics showing overall that our culture is evolving over time, and this is expected. Changing culture may take some time, but again, we have an issue about how we handle our staff when they do an error, and it is an area that we need to focus on. Here, Saudi Patient Safety, they have a regulatory document about what is the safe staffing, and mainly from nursing perspective. Here is an example, the PICU, that nurse to patient ratio 1:2 or can be fewer according to the patient need. I know this is very painful issue, staffing and manpower, but at least we have a regulatory document from the national level to define the expected nurse to patient ratio so we can move forward. I would like to utilize this very important statement from Edward Demond when he said that 85% of the reason for the failure are deficiencies on the system and the processes rather than the employee. And the rule of the management is to change the processes rather than badgering individual to do better. So here is by Jimson Reason when he have the Swiss cheese model, and the idea from this that you have a different layer of protecting or redundancy in your system to prevent error not to happen. The hole on the cheese is representing the weakness in your system. So whenever the error passes off that layer, it may affect the patient. There is an active failure, which is at the end when you have an unsafe act, and beyond that is the iceberg, when you have all the system is failing and lead to the error. They define it to organization influence, unsafe supervision, precondition that lead to unsafe act, and at the end is the active failure. So unfair to hold the last one here only accountable about the system and the management. They need to dig deeper really to help the staff and help the organization and the patient. Moreover, human factor, now they are talking about utilizing it more in the RCA analysis. So here it is the study of the interrelationship between the human tool that they use, the environment in which they live and work, and the design of efficient human-centered process to improve reliability and safety. So Dr. Thomas, he modified that it started in aviation industry, and he classified this according to the James Reason Swiss cheese model, unsafe act, precondition to unsafe act, supervision-related problem, and organization influence, and he validated already this. I will take the first trial here. When you have unsafe act, is it an error, which is something expected within the common people to do, or it is a violation? When it is an error, is it related to skill-based, or is it a decision-related error, maybe missing information, or perceptual error around what is happening around the patient? Violation, when you talk about routine violation, culture is used to break the policies and procedure, and everybody is accepting this, even the managerial. or it is an exceptional related violation. So when they done the study, and the study 72 of severe incidences, they found the majority of unsafe act is related to an error on the decision. While surprisingly, they found that there is a lot of violation is related to routine violation, meaning the culture is adapting to do mistakes. When they look to precondition to unsafe act, as Dr. Abdullah Sharif mentioned, the most common is communication, coordination, and planning. So every department or every program, they work alone. They don't need to talk to each other as a team and coordinate all the effort. I would like to share with you now a video from AHRQ. I know that most likely not anymore existing in our culture, but it is a just example on how to use the human factor. For the time constraint, I will show on the left my analysis for this.
Good morning, Mr. and Mrs. Martin. How are you today? Good.
Very good. Our grandson Max turned 5 today, so after treatment, we're headed to his birthday party.
Sounds like a lot of fun.
Oh, it will be. So it's very important that Jack's treatment be finished on time. We don't want to be a minute late.
Well, Mr. Martin, I have your supplies right here. We can get started now. You got a busy day ahead of you.
We do. Max is a special boy. He's a big baseball fan like me.
Really? Did you see the game last night? I was watching that.
Sean, I really need to talk to you about something I noticed in a chart from yesterday. I just need a second of your time.
Sure. Excuse me for a moment, Mr. Martin. Allison, what's up?
I noticed you didn't include a note to describe what you did when the blood pressure machine indicated that Ms. Alvarez's blood pressure was low. You know that it's really important to document these things.
I'm sorry I missed that. Glad you caught it.
Yeah, me too. When you finish with Mr. Martin, I need you to add an addendum to Ms. Alvarez's chart to describe what you did. Also, we're short-staffed tonight, so we don't want to be running behind.
Gotcha. Sorry for the interruption, Mr. Martin. We got to get you on. We've got plans for tonight.
Let's get going.
Excuse me, Mr. Martin. Can you hold this for me? Miss Alfreda, your catheter isn't running well today.
This thing's been acting up a lot lately.
It's really important for us to get the good blood flow that your doctor ordered. I'm going to try switching the lines to see if we can get your blood flowing so you're well dialyzed. I'm back, Mr. Martin. Let's get you finished up.
Hey, Sean, how's it going?
Not great. The next patient should already be on, but I got to clean up this blood spill.
Where's your next patient? He was supposed to have been on 5 minutes ago.
Mr. Martin took some additional time to get out of here, and now I've got a blood spill that I need to clean up.
Sean, we pay people to be on time. We don't hire staff who create their own overtime.
But it's unsafe to bring another patient in here. It's going to take me 10 minutes to clean this cubicle properly.
Look, just clean up the big stuff. It doesn't have to be perfect. And get the next patient on the machine now.
Wow, I couldn't help it over here. What are you going to do?
What can I do? You heard what he said? I'm going to knock this out quick and get my next patient in the chair.
In this example, just showing that whenever an error, now he did not follow the infection control and he done routine violation. Is it because of him? No, it is the culture that he is operating on. Resource management, inappropriate planning. We saw another staff that have no role, just going and asking and doing nothing. Supervision violation, physical environment, lack of coordination, at first mental distractions, and at the end, routine violations. So this is my end of the presentation, which about just culture. When has been released a campaign by Saudi Patient Safety, they have a policy, they have already the protocol and how you can follow that. And I will conclude my presentation with this one. It will be in Arabic, but the English translation will be down, and it will be my take-home messages.
يرتبط مفهوم سلامة المرضى بالوقاية من الأحداث المتعلقة بسلامة المرضى كالأضرار وأوجه الأذى التي قد تقع على المريض أثناء تلقيه الرعاية الصحية. لذا نسعى للتقليل من هذه الأحداث. يعد الرصد والإبلاغ عن الأحداث المتعلقة بسلامة المرضى من أهم الاستراتيجيات التي تساهم في منعها وتقليل حدوثها. إن قلة عدد الأحداث المرصودة قد يتسبب ويؤثر في استمرار حدوثها، وقد تكون قلة البلاغات ناتجة عن تخويف العاملين في مجال الرعاية الصحية من تحملهم المسؤولية ومعاقبتهم نتيجة لثقافة اللوم في المنشأة الصحية. تركيز المنشأة عند وقوع الحدث على الفرد دون وضع اعتبار الأسباب الأخرى المرتبطة بالنظام الصحي للمنشأة يحول دون مبادرة العاملين بالإبلاغ. الثقافة العادلة هي أن يكون الجميع على اتفاق بأن مسؤولية أحداث سلامة المرضى مسؤولية مشتركة بين النظام الصحي والعاملين فيه. الثقافة العادلة هي بيئة من الثقة يتم فيها المشاركة بين النظام الصحي والعاملين في مجال الرعاية الصحية على تحمل مسؤولية أحداث سلامة المرضى، وذلك من خلال دعمهم ومعاملتهم بشكل عادل عند وقوع هذه الأحداث أثناء تلقي الرعاية الصحية. تبني مبادئ الثقافة العادلة يساهم في خلق بيئة أكثر أمان وشفافية، ويساعد في إيجاد مواطن الخلل داخل النظام الصحي بدل من التركيز على الفرد، مما يعطي فرص حقيقية لتحسين سلامة المرضى في المنشآت ومنع الكثير من الأحداث من الحدوث. أسهم إرساء مبادئ الثقافة العادلة في كثير من المجالات غير الصحية في تمكين الأشخاص من الإبلاغ وزيادة عدد البلاغات المرصودة، مما أدى إلى وضع التدابير المناسبة لتفادي المخاطر والأحداث وتعزيز السلامة. ثقافة عادلة نحو رعاية صحية أكثر أمانا.
This is my references, and thank you so much for your listening.
Thank you, Dr. Hassani. I think we'll just have a few minutes before the opening will occur in the counterpart conference room. So thank you so much for attending, and we'll see you after there's the opening ceremony, then I think lunch after that, then I'm going to meet here again for further lectures. Thank you.
Thank you, everyone. The opening ceremony will be in the adult hall in the other side, and that we're going to have the lunch break. For the speaker and the moderator, it will be in a Safina restaurant in the basement of the hotel. Thank you, everyone.